Hi everyone, my name is Kisa Rothmich, and today me and my peers, Clarence, Katie, and Esther are going to present global health security and disaster risk reduction.
So we're going to start with the definition of what is global health security. The World Health Organization defines global health security as the activities that requires both proactive and reactive to minimize the danger and impact of acute public health events that endanger people's access across geographical regions and international boundaries. I think the CDC has a more palatable definition, and they describe it as the existence of a strong, resilient public health system that can prevent, detect, and respond to infectious disease threats wherever they occur in the world. And that is their latest definition as of this year. Some of our top current global health security risks are the spread of highly infectious diseases. And that's a huge threat, as we've seen with the current pandemic. And it's not just SARS that can be a threat, but any highly infectious pathogen that is a risk to global health security. This could be the flu, measles, polio, pertussis, etc. The United States has vaccines and treatments to lower mortality rates, but developing countries may not, and it can severely impact them with high mortality rates. Globalization is another hazard, as it only takes 36 hours for a highly transmissible disease to be around the world. For example, on January 9th of 2020, the World Health Organization announced there was a mysterious new pneumonia-like disease in Wuhan, China. And 2.5 weeks later, on January 1st of 2020, the first known US case was announced in Washington state. Additional global health security risks include the increase of drug-resistant organisms such as MRSA and MDR-TB, and the illegal use of dangerous pathogens that could be used in biological warfare. To highlight some of the importance of global health security, I'm going to look at some past outbreaks that put the current healthcare systems to the test. I'm not going to go through all of the examples here on screen, but I'm going to highlight some of the pivotal ones. The first SARS epidemic in 2003, SARS being severe acute respiratory syndrome, infected approximately 8,000 people and killed 777 in a total of 29 countries. The outbreak lasted 6 months, and many countries imposed travel advisories for Toronto, Hong Kong, Taiwan, and China. The virus was found to be related to civets, and so the United States imposed a ban on civet imports in 2004, which is still in place today. The 2003 SARS epidemic paved the way for SARS to be added to the National Select Agency Registry Program, which determines which pathogens pose a severe threat to public health. This epidemic is estimated to have cost close to $40 billion. In early 2014, Ebola was detected in Guinea and quickly spread to its border countries, Sierra Leone and Liberia. And due to weak public health infrastructure and support, it lasted several years. After 2 years, in June of 2016, the outbreak ended, with all affected countries reporting to be Ebola-free. In total, there were 28,652 cases, 11,325 deaths in a total of 10 countries. This is estimated to cost around $4.3 billion for mitigation and recovery. Now, these outbreaks showed the weaknesses in healthcare systems and proved that highly infectious diseases need an international multi-sectoral approach to mitigate deaths and maintain economic stability. Now, for the history of global health security, it started formally as the International Health Regulations, and it's monitored by the World Health Organization. It's comprised of 196 countries, including all member states of the WHO. The main goal of the IHR is to limit the spread of health risks and trade restrictions that would occur as a result of a global health event. The IHR requires that all countries can detect any potential disease threats, assess the scale of that threat, and report it to the WHO, and then respond appropriately as seen in the infographic to the right. You can see assess, report, respond, and detect. They also developed the legal framework for countries' rights and expectations in emergency public health situations that have the potential to be international events. In their development, they also created the official definition for a public health emergency of international concern. This is the IHR's decision tree to determine if a public health emergency is of international concern. If a public health event fits the criteria for two of these questions, it must be reported and acted on. What's interesting on this is on the left-hand side box, you can see SARS in the list of pathogens, where if there's any unusual or unexpected activity, it's meant to be reported immediately. This document can be found on page 43 of the International Health Regulations, 3rd edition from 2005. Some current health security risks domestically is the COVID-19 pandemic with over 45 million cases, 749,000 deaths, and an estimated cost of $16 trillion. One of our biggest issues at the moment is a lack of vaccine access. Another domestic issue is influenza, and we're just starting the flu season, and already there's been one novel influenza A virus detected in the state of Ohio. International health security risks include the COVID-19 pandemic with 248 million cases, and we did just cross the threshold for 5 million deaths worldwide. Some other health security risks include heart disease, which kills approximately 8.5 million people yearly, and malaria, which has 229 million cases worldwide in 2019, with over 400,000 deaths. Some key organizations and countries that assist in global health security would be the United Nations, USAID, the CDC, the WHO, the Global Fund, and the Global Health Security Agenda. Some additional countries include the United States, Canada, the United Kingdom, Spain, Korea, Japan, Australia, South Africa, and Argentina are some of the key players.
Hi, everyone. My name is Esther, and I'll be discussing some of the global health initiatives and organizations that are working towards change in global health security. The Global Health Security Agenda's 2024 framework was created in an effort to achieve safety and security from global health threats through multi-sectoral and multi-stakeholder work. Some of the work includes identifying and addressing gaps in health, building political will, and investing in health security overall. The goal is that by 2024, 100 countries would have completed a full evaluation of their health security capacity. This is to ensure that they are implementing impactful and essential interventions that strengthen health security overall. The United Nations agenda in global health includes 3 parts. There is a security agenda, economic agenda, and social justice agenda. Basically, the security agenda encompasses the need to protect the international spread of disease. When we look at this section of the global health agenda, its efforts are towards ways we prevent the next pandemic to come. The economic agenda combats poor health outcomes in effort to improve the economy. For example, today, when we look at the COVID-19 pandemic, we see how it greatly impacted the economy, especially when it comes to vulnerable populations. The social justice agenda addresses the need to advocate for all human rights and ensure equal access to all members of society in effort to support global health. This is all about health equity, equality, and ways we support each member of our respective nations, regardless of gender, race, or age, etc. Organizations like the World Health Organization, Centers for Disease Control and Prevention, the United States Agency for International Development have adopted a prevent, detect, and respond approach to global health security. The first step is prevention. Prevention is key in this approach because it allows health professionals to take the appropriate measures at preventing disease and avoidable deaths and reducing the burden of healthcare costs. Detecting threats early allows people to prepare for and take the necessary actions to prevent disease. And responding entails taking action towards detected diseases and being able to contain the impact of it.
Hi, like I said earlier, my name is Kiesler, and I'm going to be going over the variability of global health security in relation to disaster risk reduction and how it affects international morbidity and mortality. So as of right now, where we're standing, 65 countries have committed to better implementation of global health security, but that's only 65 countries. Disasters worldwide have a huge and vast number of complications in all countries. One of these a good example of this is in 2011, disasters alone estimated $370 billion worldwide. A good function of the disaster health relief, it's only been restricted to emergency response. So when you think about disaster health relief, it's kind of like tertiary prevention, and that actions are made in order to aid after the effect has happened instead of prevent measures overall. And so the purpose of disaster risk reduction strategies are to take proactive risk strategies per each health sector and then figure out what is best for that health sector in order to reason and figure out how to go about in the future on lowering the disaster risk reduction. And so that's one of the big issues that we have right now with disaster risk overall, and it varies country to country and how they take on that and the actions that they do to reduce any disaster risk. The CDC, or the Centers of Disease Control and Prevention, has articulated 3 agency policies for global health security, and those are to secure global health and America's preparedness, eliminate disease, and end epidemics. Some big key partners in the CDC and their mission statement and these 3 agency policies are finding effective partnerships because they are critical for attaining and sustaining programs for disaster risk reduction and global health security. Global public health and local public health are inextricably linked. So if we focus on either local public health or global public health for these 2 factors, one will definitely reduce, and that can help communities individually as well as the overall population in which these individual communities are a part of. Progress in global health security requires having metrics that are monitored, reported regularly, and continuously evaluated. So those 3 factors on different levels play a huge part in the variability of global health security internationally as well. So in terms of morbidity and mortality, the significance of global health security and disaster relief can be evaluated on several different levels. They don't have a direct result together, though. They direct overall measures. They impact them directly, but they don't have individual direct results. An excellent quote to sum all of this up is that a health threat anywhere is a health threat everywhere. And that can be seen with COVID-19, which we're all familiar with at this point. So the health threat, which began in Asia for COVID-19, it became a health threat everywhere. So everyone became accustomed to it, knowing what it was like to deal with it in the population. And so that is an example of not having a preventative measure, but doing emergency response to the COVID pandemic, because it's a disaster relief in which emergency responses had to be enacted immediately. Another good example is the Ebola epidemic in 2014, which Katie touched on, in which 70% of countries were not prepared to respond. And so that emphasized the overdue and urgent need to implement core facilities and capacities of the WHO in order to aid everyone dealing with the epidemic of Ebola and how to figure that out and get that reduction and security in place to prevent something like that in the future. Research, however, does not support vulnerable populations being negatively and differentially affected by disasters. And these vulnerable populations can be women, children, the elderly, non-documented immigrants, and underrepresented groups, or the poor. So they aren't directly effective. However, literature on mental health morbidity shows that a vulnerable person is particularly prone to post-disaster stress, or PTSD. So while they're not impacted immediately, they do have lots of PTSD and mental health issues following up to those disasters and things that they experience directly. Another interesting point is that age is the only characteristic that has weak association with disaster-related morbidity and mortality. So it doesn't matter how old you are, and minimize your specific circumstances in which you're in and how you're directly impacted by those disasters and global health security's effect. Some major disparities right now is as of 2025, it's estimated that 80% of the world's population will be concentrated in developing countries. And in developing countries, half of large cities are vulnerable to natural disasters and disease-related health problems. So those two statistics combined are showing that by 2025, a majority of the planet is going to be at risk for some of these global health security and disaster risk reduction issues. And so that's why it's really important to look at the vulnerability of populations and how it varies country to country and the morbidity and mortality to see what we can do, because in the next 4 years, who knows if we're in COVID in 2021, who knows what's going to be in 2025 when the majority of the population is going to be suffering, or in developed countries having these disaster risk reduction issues. Another reason as to why currently we are having disease-related health problems in relation to global security is there's an exacerbated number of lower immunization rates and poor nutritional status in developing countries. And so those are key factors in having weak immune systems and be able to fight off any disease risks or global health matters that could cause an issue in security. Additionally, the vulnerability of facilities in providing water and handling sewage. Those are two extremely important SDGs, in which obviously clean water and proper sewage handling comes into play. And so those, if they're not treated properly, also have huge factor and play in disaster risk and global health security.
My name is Clarence A.K. Vandi. I'll be discussing the remainder of the presentation on why the goal of global health security remains elusive. And I would like to start off by just picking back on what Kisla just said, that in the next 4 years, 80% of the world's population will be living in undeveloped or underdeveloped countries, especially within metropolitan areas, and why it is very important for that huge population to have access to health equity. So why is it that after all the investments by the world community, investments in global health, that the goal of global health security remains elusive? Well, one of the things we look at is the tacit, the quiet acquiescence, and even facilitation of corruption, especially by leaders of underdeveloped countries, and the illicit outflow of money from unfair trade and other corrupt practices. For example, the United Nations Trade Group estimates that Africa could save $89 billion a year just by curbing illicit capital outflows, mostly from corruption and unfair trade practices. This is money that can otherwise be used to address health issues, build health institutions, not just health institutions, but also surveillance and reporting infrastructure. They also report that the illicit flight from Africa because of trade, the illicit money that is flowing from Africa is just over $800 billion in 2018. And if this is the case, then Africa is actually then a net exporter of resources. So at the end of the day, why is so much money really leaving Africa? It's because the international community, in spite of all the investments in health security, in making sure that the world community is protected, that they have the capacity to detect, protect, and report disease outbreaks, we have not been able to address this particular aspect of global international cooperation in order for us to stop the illicit outflow of capital from Africa, so that that money can remain in Africa for leaders to develop their healthcare systems and surveillance and reporting infrastructure. Because the governments are not able to keep just much money in their countries, underdeveloped countries especially have diminished capacity to create the sustainable process to educate and to create employment opportunities. As we have seen, the attainment of global health is tied directly to the equity in education, the creation of or the facilitation of corruption. Corruption would mean where especially under the leaders of underdeveloped countries siphon money out of their countries into developed countries, into banks in developed countries, and also the illicit financial flow that comes from unfair trade practices really diminishes the capacity of these countries to create good education systems and sustainable healthcare infrastructure. As we know, education is the most important social determinant of health, and it does not only create employment opportunities. Education is associated with life expectancy, is associated with morbidity, and is associated with mortality and other health behaviors, and therefore health outcomes. So without these countries having the capacity to create a quality education system, they are not in any position to be able to develop and maintain the type of infrastructure we're talking about when it comes to health security, global health security. So again, we have to then work together as an international community. The global community has to work together to make sure that these outflows from illicit trades and corruption are stopped in order for those countries to be able to redirect the usage of those resources to develop their education systems, and by extension then develop a good sustainable healthcare infrastructure. One of the things also is that international organizations, the world community, has really not been able to understand the underlying systemic inequities among governments. For example, here in the United States, we have a myriad of health infrastructure, health institutions, from the CDC to the NIH. I mean, there are lots of health institutions within the United States and in other developed countries that all work together to make sure that the goal of health security is attained. This is not the same thing with other countries. Other countries, for example, in Sierra Leone and Liberia, for example, are just now beginning to even understand how to create these institutions in the face of the 2014 Ebola outbreak and now the COVID-19 outbreak. So as a result, most underdeveloped countries or developed countries don't really have any capacity, or they have minimum capacity to actually create systems that will be able to contribute toward this global health security goal. And the international community, for the most part, has not been able to grapple with this to understand that there are systemic inequities, disparities between governments or amongst governments to create systems that really can contribute to maintaining or achieving global health security. For example, the COVID-19 pandemic saw both developed and developing countries competing for personal protective equipment at cost that the developing countries can afford, but the underdeveloped countries do not afford. And so as a result, not only that the developed countries have more doctors, they have access to more PPEs, the underdeveloped countries and the developing countries don't have the same access. For example, in countries like Sierra Leone, again, Liberia, the Ebola virus decimated much of the healthcare workers. Doctors died. Some of the doctors actually died in this country, in the United States, when they were transported here for care. And thousands of healthcare workers died also, and they remained still vulnerable to the current COVID-19 pandemic. So this lack of understanding has created a lack of coordination, a lack of creating the systems, and also the production capacity to be able to respond to global health crises like COVID-19. So in a case with COVID-19, developed countries where everybody was scrambling for their own countries, and rightly so. But if we are working as an international community, as a global community, to make sure that we have global health security, individual countries should work together, not independent of other countries. Because what happens in one country can affect another country within a few hours. So that is the reason why the 196 countries that are part of this international health regulations in its 2005 pact should work together to make sure that there is a coordination, not just in the amount, the quality of healthcare personnel, but the amount of healthcare personnel and also access to care and personal protective equipment. Another thing that makes the goal of global health security elusive is that we are not transferring skills and knowledge across the world. For example, we have the CDC here. We have structures here, infrastructures here in the United States and other developed countries that basically track disease, track vaccination rates, track access to vaccination, track access to care. In underdeveloped countries or developing countries, such systems don't really exist. So as a result, we're not able to create the type of healthcare surveillance systems and reporting systems that can contribute toward the attainment of global health security. For example, the central theme of the United Nations Sustainable Development Goal in the Global Health Equity Initiative is leaving no one behind. But then how can we not leave people behind when not all countries there's no level playing field amongst countries when it comes to equity? Policymakers, for example, in developed countries, do not see the transfer of health skills, knowledge, and technologies to other developed countries as part of a public policy initiative. And because that is the case, it is difficult for underdeveloped countries or developing countries, some developing countries, to actually be able to create these systems. As a result, if there is an outbreak in one underdeveloped country, as happened in 2014 in the case of the Ebola virus, it is easy for that country to transport that disease across the globe, even if it is not their own nationals that are leaving to go to other countries. Sometimes nationals from developed countries doing business in these underdeveloped countries or developing countries travel and return to their home countries and bring the disease along with them. That is why, in order for us to achieve this goal of global health security, it is very important for countries with the know-how, the knowledge, the technology, and the skills to share or transfer these resources to underdeveloped countries or developing countries so that there is a global access to knowledge, technology, and skills. Without this sort of collaboration, it is very difficult for developing countries or underdeveloped countries to create sustainable healthcare systems that include robust surveillance and reporting systems. Another thing that makes it difficult for us to achieve global health security is the lending policies of the IMF, the International Monetary Fund, and the World Bank. Most people may not know that, for example, the IMF and the World Bank, when they go into countries, they provide debt, especially to underdeveloped countries. They give them loans that have high interest rates and strict conditions, very stringent conditions. Back in the 1980s, there was this phrase called Structural Adjustment Program, SAP, that the World Bank and the IMF required developing countries and other underdeveloped countries to implement in their economies in order for them to qualify for IMF or World Bank loans. Well, what happened was that these requirements forced these countries, developing countries and underdeveloped countries, to cut public expenditure, public investment in things like education and healthcare. So as a result, while these countries are paying up the debt, this high interest debt, they're not able to invest in education and healthcare. As a result, they're not able to contribute to a global system that contributes to global health security. Just 2 days ago, the president of Sierra Leone, Julius Maada Bio, at the United Nations Global Climate Change Conference in Scotland, said that his country was not able to really undertake programs to cut back emissions because of the enormous debt burden they have in their country. So this is just one country. How much more if we're looking at other developing countries or underdeveloped countries that are saddled with IMF and World Bank loans as stringent conditions and high interest rates that they're not able to actually spend money or divert resources from paying these debts to make investments in healthcare and healthcare infrastructure. So high interest rates and trade liberalization policies like privatization have affected the local populations in underdeveloped countries, and this is making it very difficult for the economies of those underdeveloped countries to grow in order for them to respond to the needs of their populations. And as such, they're not able to create healthcare systems that respond to this global health security goal. So as we've said, the IMF interest rates and trade liberalization policies are affecting the developing countries and underdeveloped countries in making sure that they can divert some of the loan payments that they make, especially high interest loan payments that they make to these countries, for them to be able to develop healthcare systems by investing in healthcare systems, creating healthcare personnel, training healthcare workers, and creating the structures that would enable them to have surveillance and reporting systems that contribute toward the global health security. So what is the solution to all of this? If we are going to invest so much money, so much resources in global health security so that we can achieve equity in global health, one of the first things we need to do is to facilitate fair trade. By fair trade, we mean, for example, when you extract minerals from underdeveloped countries and you take those minerals in their raw form without adding value to those minerals, you are typically robbing those countries of employment opportunities. And because they don't have employment opportunities, they're not able to get tax revenue, they're not able to educate their people, they're not able to create the revenue base so that they can create the healthcare infrastructure that contributes to global health security. We also have to minimize the illicit capital flows out of underdeveloped countries and developing countries. Illicit capital flows amount to over 800 billion, almost $1 trillion yearly from underdeveloped countries. By this, we have to make sure that leaders of developing countries or underdeveloped countries who siphon money out of their economies into banks in the West are discouraged from doing so by taking those monies and giving them back to their countries, not necessarily to the same leaders, but by creating structures in place as deterrents for these leaders to be able not to send these monies out of their country into their private bank accounts in Western countries. We also have to embark on fair trade policies. Again, fair trade policy means that as we go into developing countries or underdeveloped countries that have the natural resources, we should be able to extract the natural resources, add value to those natural resources while they are in that country so that it gives them an opportunity to create more jobs and empower their people economically. These are some of the things we can do in order for us to achieve global equity in health. If we do these things as a global community, if we work together as a global community, it is possible that together we can bridge the gap in global health equity or in the inequities in access in healthcare. We can bridge the gap, make sure that we empower individual countries, especially underdeveloped and developing countries. We empower them with the knowledge, with the skills, the technology, and the economic wherewithal for them to be able to create the structures, the infrastructure that report, surveil, and also prevent global health outbreaks as we do in the West. So this is our presentation. We are recommending these ideas to the global community so that together we can achieve equity in global health. Also, we're looking at creating a legal framework, and this is really important. So we have the Geneva Conventions that are binding on almost all countries to, for example, treat prisoners of war humanely. So these conventions are binding through international treaties. Why can't we, the global community, then create a global health system, not just as a suggestive endeavor, but to make sure that we create these policies as global policies through treaties that hold nations accountable for the attainment of global health care system that minimizes the proliferation and ensures that disease surveillance and reporting are binding on those countries. The world should declare education, for example, and universal health care as human rights, because without education, it is impossible, almost impossible, for populations to be able to act in a way that will improve their health. And so education should be a universal human right as much as healthcare itself is. Government should be compelled to give priority to education in their national budgets, and the international community should make sure that governments are compelled to give such rights to their people. Like the Geneva Conventions and other binding treaties, international community should make sure education and healthcare funding are binding on all organizations or all countries, knowing that when people are educated, they act much more responsibly toward their own health and therefore contribute to the attainment of global health equity.
I think that's it, guys. I think my slides